Disorders of the hematopoietic system. Anemia is a deficiency of erythrocytes or hemoglobin. It can be caused by blood loss, inadequate erythrocyte production, and destruction of formed red blood cells. Excuse me. These clients will have an inadequate red blood cell count, orthostatic hypotension, thready pulses, oliguria, which is decreased urine output, and heart murmur. Compensatory mechanisms for lost red blood cell function include tachycardia, because what do the red blood cells do? Hemoglobin carries oxygen to the tissues. So if we don't have enough red blood cells, then we don't have enough oxygen. So we have tachycardia, trying to get that blood moving faster through the system to bring more oxygen. Tachypnea, they're breathing faster to get more oxygen. The skin will be cool and clammy, and clients who are in the reproductive stages, the females, will have amenorrhea. We can also see decreased red blood cell function, so these clients are dyspneic. They can have discomfort in the chest, acidosis, headache, vertigo, and pallor. Types of anemia include hypovolemic, iron deficiency, pernicious, folic acid deficiency, sickle cell, and hemolytic. With hypovolemic anemia, it's caused by a sudden loss of a large volume of blood or a chronic loss of small amounts of blood. These clients may have extreme pallor, so they're very pale, tachycardia, hypotension, reduced urine output, altered consciousness, fatigue, chills, and a rapid respiratory rate. Remember, once again, hemoglobin transports oxygen to the body, so decreased hemoglobin may result in poor perfusion symptoms. Diagnostically, we look at the CBC. We can also look at imaging or visualization procedures to determine the source of the bleeding. Medically, we're going to possibly do blood transfusions. We need to be sure that we treat that underlying condition or cause of that blood loss. We can also administer oral, IV, or intramuscular iron to help restore hemoglobin. With iron deficiency anemia, we have insufficient iron to produce the hemoglobin, where the heme cannot be recycled because of blood loss. Iron intake might be insufficient, or the iron needs outweigh the intake, or we're unable to absorb that iron. These clients will have reduced energy, they'll feel cold all of the time, they may have fatigue or dyspnea with minor physical exertion, a rapid heart rate even at rest, decreased hemoglobin and hematocrit, and decreased serum iron levels. So once again, we need to find the cause and eliminate it, encourage foods that are high in iron, and administer oral or parenteral iron. Iron is a supplement, and we give this for iron deficiency anemia prevention or treatment. It is contraindicated if there is an allergy or iron overload or hemolytic anemia. Adverse effects of iron can include nausea, vomiting, diarrhea, constipation, stomach cramps, or pain. It does turn stools dark green or black, so it can look as though there might be blood in the stool, and there's not. And it can also stain the teeth. So it's very important to mix oral forms in fluids or use a straw to help prevent contact with the teeth. It does interact with ascorbic acid. Ascorbic acid, such as orange juice, will help improve the absorption of the iron, but it does decrease the absorption of tetracyclines and quinolones, which are antibiotics. The different forms that we may see would be ferrous fumarate, ferrous sulfate, iron dextran, ferric gluconate, and iron sucrose. We can also do blood transfusions in addition to these supplements. Nurses need to make sure that we're educating on forms of foods that have increased iron, collaborate with a dietitian, give that iron supplement, and just as iron can stain the teeth, if we're giving this intramuscularly, we have to use the Z-track method because it can also stain the tissues. Client education, make sure that we let them know that their stools may be black or dark green, and to take or drink vitamin C with oral forms of iron, making sure that they don't take iron with antacids and take iron on an empty stomach. And if they're taking liquid iron, to make sure that they use a straw to avoid that tooth staining. So question, a client requires an injection of parenteral iron for treatment of iron deficiency anemia. The proper route and site for administration of parenteral iron includes which of the following? This includes D. It's intramuscular, Z-track, and it should go in the gluteus muscle. Sickle cell anemia is where the hemoglobin changes shape. The hemoglobin becomes an S-shaped or a sickle or crescent-shaped, and that is due to inadequate oxygen supply to the blood. This is a hereditary condition, and it's most common in African Americans. However, it's also found in Mediterranean, Middle Eastern populations. These clients may experience what we call a sickle cell crisis, where we have abnormal cells lodging in blood vessels that cause severe pain due to ischemia, which is the lack of oxygen to the tissues, tissue infarction, where the tissue actually dies because of this lack of oxygen, and stroke. These clients may have splenomegaly, which is an enlarged spleen, and this increases the infection risk. They may have jaundice, gallstones, chronic leg ulcers, priapism, which is an extended penile erection not related to sexual desire, tachycardia, dyspnea, cardiomegaly, and dysrhythmias, an acute chest syndrome, which includes coughing, wheezing, tachypnea, and chest pain. We diagnose it with a Sickle Dex test. We can also do hemoglobin electrophoresis. Medically, supportive treatment is very important. They may require regular blood transfusions, bone marrow transplant, prophylactic antibiotics. And if they develop that sickle cell crises, narcotic analgesia, because pain is extremely severe, oxygen, bed rest, IV fluids, and medications. Remember, with sickle cell anemia, they're not getting enough blood. So we need to make sure that they avoid triggers that can increase the risk of a sickle cell crisis. So this is going to include things that increases or they need to avoid things that increase oxygen consumption or decreases the perfusion of oxygen to the blood or to the tissues, such as anything that is vasoconstricting, such as tobacco. Higher elevations increases oxygen demand. Stressors, so they need to avoid stress. Infections can increase that oxygen demand. So a variety of things that can increase the oxygen demand or cause vasoconstriction can cause a sickle cell crisis. So clients need to be educated on things they need to avoid. This is your mnemonic for sickle cell crises. So a 20-year-old client is experiencing a sickle cell crisis. Which of the following interventions will be indicated for this client? Assessment of the client's pain every 4 hours. We do need to increase their fluid level to help prevent the clumping of these abnormal cells, but making sure that we teach them things to avoid the crises to begin with, and hopefully we can prevent these episodes or minimize them. Hemolytic anemia is a chronic premature erythrocyte destruction. Can be caused by cardiopulmonary bypass, poisonings, malaria, and exposure to hazardous chemicals. These clients may have jaundice, an enlarged spleen. They can even go into shock. On microscopic examination, we see a positive Coombs test. We're going to treat these clients by removing the cause, administering corticosteroids, and maybe even doing blood transfusions. Surgically, it may be necessary to remove the spleen, so a splenectomy. Nursing-wise, make sure you get that good health history. We're going to administer supportive care, medication, and teach measures of self-care, and help arrange for follow-up evaluations. Pernicious anemia is due to a lack of an intrinsic factor that's necessary for the absorption of vitamin B12. It can cause degenerative changes in the nervous system. It can also be secondary to surgical removal of the stomach or a small bowel resection. So clients that have bariatric surgery are especially prone to pernicious anemia. These clients may experience stomatitis, glossitis, digestive disturbances, diarrhea, dyspnea with minimal exertion, jaundice, irritability, confusion, depression, numbness and tingling in the arms and the legs, and ataxia. We diagnose by looking at blood and bone marrow studies, a Schilling test, or a blood smear. We're going to treat it by administering IM vitamin B12. Vitamin B12 is a supplement, and it's indicated for these deficiencies that are due to malabsorption, gastric bypass surgery, and pernicious anemia. Contraindications are, of course, the drug allergy. It can cause itching, transitory diarrhea, and fever. It does interact with a concurrent use of anticonvulsants, aminoglycosides, long-acting potassium, all decrease vitamin B12 absorption. Physical therapy may be necessary if there's any permanent neurologic defects. With these clients, nurses need to instruct with the glossitis and stomatitis. They need a soft, bland diet, small, frequent meals, and oral care. With the permanent neurologic deficit, we need to encourage and assist with ambulation and supervise them. And we also need to teach them about the administration of that vitamin B12, in addition to encouraging foods that may be high in vitamin B12, such as meat, eggs, fish, and milk. So a client who has undergone a hemogastrectomy has been diagnosed with pernicious anemia. The client asks the nurse what might have caused her problem. Which of the following is the nurse's best response? You are no longer able to absorb vitamin B12 because of your surgery. Folic acid deficiency anemia is caused because of immature erythrocytes and insufficient dietary intake of folic acids rich in folic acid. It's often found in clients that have alcoholism, intestinal disorders, poor nutrition, and pregnant women. These clients may experience severe fatigue, a sore, beefy red tongue, dyspnea, nausea, anorexia, headaches, weakness, and lightheadedness. We diagnose it with a Schilling test. Medically, we want to administer folic acid supplements in addition to a balanced diet. So folic acid supplements are used to prevent and treat folic acid deficiency, also to prevent neural tube deficits in pregnancy, and it's used as a topical sprue treatment. Contraindications include a drug allergy. We don't use to treat anemia unless the cause is determined. Adverse effects, allergic reactions, and it can change the color of the urine to a different yellow color. It does interact with some drugs, and the drug name is folic acid. Nurses need to teach diet, oral hygiene, and promote rest. Leukocytosis or leukemia is a proliferation of leukocytes, usually in an immature form. There's 4 types of leukemia according to dysfunctional bone marrow stem cell line. It can be acute and chronic lymphocytic leukemia. These will be from the bone marrow dysfunction affecting the lymphoid stem cells, and acute and chronic myelogenous leukemia, which are in the myeloid stem cells. Precipitating factors for leukemia include genetic correlation, exposure to toxic chemicals, radiation, viruses, and some drugs. These clients will have severe anemia, infections, fatigue, easy bruising, fever, enlarged spleen and lymph nodes, and internal or external bleeding. We're going to manage it with anti-neoplastic drugs, basically chemotherapy and blood transfusions, and it may require bone marrow or stem cell transplants. So here is a mnemonic for leukemia symptoms. Multiple myeloma is a malignancy that involves the plasma cells. The osteoclasts will begin to break down bone cells, and this results in an increased blood calcium level. And since that calcium is being pulled out of the bone, It weakens the bone, so we have those pathologic fractures. We may also see osteolytic tumors or a punched out or honeycombed appearance in the bone. These clients have pain, infection, anemia symptoms, bruising, nosebleeds, renal calculi because we have increased calcium in the blood, renal failure. And we may also see what we call CRAB. Calcium levels are elevated, renal insufficiency, anemia, and bone lesions. We diagnose with the skeletal X-ray studies, bone lesions, elevated serum calcium levels, bone marrow aspiration, which may show an increased atypical plasma cell. We're going to treat it with steroids, anti-cancer drugs, and antibiotics because remember, we're looking at issues that may cause infection. Analgesics, blood transfusions. They may require back braces or body casts. Surgically, we can do a bone marrow or stem cell transplant. Nurses need to assess for pain, signs of infection, fatigue, bleeding, thrombus formation, and assess their urine output. Analgesics, ambulation, fluid intake, and safety are all going to be paramount in caring for these clients, in addition to preventing infection. Agranulocytosis is a decreased production of granulocytes, neutrophils, basophils, and eosinophils. Remember, these are all going to be part of the white blood cell count. They're caused by toxicity from some drugs. These clients may experience fatigue, fever, chills, headache, and opportunistic infections. You know, our body has lost its ability to fight off these infections. So what is normal flora on our body may now become an infection. We're going to treat by removing the cause, administer appropriate drugs, doing a human granulocyte colony stimulating factor, which will be an injection. Nurses need to assess the client's drugs. What medications are they taking? Are they in protective isolation? And we may need to restrict visitors because these clients are not going to be able to fight off infections, and visitors can bring what are normally harmless bacteria into these clients and create infections. Aplastic anemia is going to be due to the failure of cells to develop because of inadequate stem cell production. It can be an autoimmune cause or exposure to toxic chemicals, radiation, or drug therapy. These clients are very ill, and this can be a fatal issue in cases of severe bone marrow damage. These clients will experience weakness, fatigue, those opportunistic infections. They may have unusual bleeding, petechiae, and ecchymosis, an enlarged spleen, and abdominal pain. We're going to diagnose with the blood cell count and bone marrow aspiration. We'll treat it by withdrawing that causative agent, transfusions, antibiotics, corticosteroids, and we can also do a bone marrow transplant. Nurses need to obtain a good history, do a good physical assessment, and observe for any symptoms. Infection prevention measures, which may include isolation, good nutrition. We may need to modify oral hygiene because these clients, the bone marrow is affected, and that includes red blood cells, white blood cells, and platelets. So they're going to be at an increased risk for bleeding. So we need to do those bleeding prevention measures. And we also need to monitor any blood transfusions that may be administered. Thrombocytopenia is going to be a coagulopathy where we have a component to control bleeding that's missing or inadequate. So this does include thrombocytopenia and hemophilia. So thrombocytopenia is going to be a decreased platelet count. We have a platelet manufacture by the bone marrow being decreased or destroyed by the spleen. Causes can include leukemia, malignant blood diseases, and severe infections. These clients can have what we call purpura, which is going to be multiple little tiny petechiae all over the body, bleeding, and internal hemorrhage. So it's important to eliminate the cause. We may administer corticosteroids and transfusions. Surgically, we may need to remove that spleen. Again, we need to institute bleeding precautions and watch for adverse drug reactions. Excuse me. And if they're getting the corticosteroids, taper them. With hemophilia, this is due to an absence or reduction of a clotting factor. It would be the clotting factor 8, 9, or 11. It is inherited and it's passed from mother to son. Women can develop this disease, but it is very, very rare. These clients are going to have persistent oozing, severe bleeding in the joints. We diagnose with a coagulant factor assay. We're going to transfuse them. We can give thrombofibrin application. They may get fresh frozen plasma and direct pressure. Nurses need to get a good health history, do a good physical assessment, watch those vital signs, prevent trauma, minimize bleeding, and reduce pain or discomfort. We also need to teach ways to conserve energy and ways to prevent further episodes. So again, bleeding precautions. These are your bleeding precautions, so memorize Randy. DIC, Disseminated Intravascular Coagulation, occurs when there's an overstimulation of the normal coagulation cascade that results in simultaneous thrombosis and hemorrhage. It's what we call a hypercoagulable state. DIC is always secondary to another pathologic process. The client may have had overwhelming sepsis, shock, major trauma, crush injuries, burns, cancer, acute tumor lysis syndrome, or obstetric complications such as abruptio placentae or fetal demise. What happens is coagulation will occur at so many sites that the body has been responding by sending all these platelets to these sites that we now have depleted the platelets and clotting factors. So now we have uncontrolled hemorrhage. Blood tests that help diagnose DIC include the prothrombin time, the partial thromboplastin time, fibrinogen, thrombin time, fibrin split products level, and D-dimers. Treatment can include blood component replacement therapy, heparin to interrupt the DIC cycle and allow the body to replenish platelets and clotting factors, but both of these treatments are controversial. You know, we have clotting going on, but we also have bleeding going on. So we give more clotting factors, we give blood thinners. It's 6 of one, half a dozen of another. So one of the things that we may give are going to be your antiplatelets, which help reduce the risk of stroke or thrombotic stroke, TIAs, prevention of thrombosis, or acute unstable angina or MI. It just basically is going to help prevent the congregation of platelets. It's contraindicated with drug allergy, thrombocytopenia, active bleeding, leukemia, traumatic injury, GI ulcer, vitamin K deficiency, and recent stroke, because it can cause serious bleeding episodes. We may also see nausea, vomiting, or flu-like symptoms, or dizziness. And of course, it interacts with NSAIDs and steroids. These drugs would be like aspirin, clopidogrel. Your anticoagulants are going to be given to prevent clot formation in clients that have a history of clots or risk of clots. Contraindicated with allergy, acute bleeding processes, or risk for bleeding. Warfarin is contraindicated in pregnancy. Your low molecular weight heparins, such as Lovenox, would be contraindicated with an indwelling epidural catheter. Of course, bleeding would be the main complication, and that can be localized or systemic. We can also have heparin-induced thrombocytopenia with heparin, and warfarin can cause skin necrosis and purple toes. It does interact with any drugs that increase the anticoagulation activity. So antidotes for warfarin is going to be vitamin K. An antidote for heparin would be protamine sulfate. So these drugs, once again, orally, warfarin is going to be one of the main ones. Subcutaneous and IV can be your heparin. We can also do the low molecular weight heparin, such as Lovenox. Make sure that if you administer Lovenox, this is a sub-Q. The generic name is enoxaparin. If we administer enoxaparin sub-Q, do not expel that air bubble prior to administration. Very important to not do that. And we also have argatroban, which can be administered IV. Heparin can be administered subcutaneously or IV. And then we look at our thrombolytics, which break down those clots in various situations where clot is causing ischemia. Adverse effects include internal, intracranial, and superficial bleeding, nausea, vomiting, hypotension, cardiac dysrhythmias. Those contraindications are going to be recent injuries where there has been a large hematoma or recent surgery, head injuries, anything, because that bleeding can be reestablished with the thrombolytic. This drug is often caused alteplase, or referred to as TPA. If you look at the picture in this slide, you can see that this client is very ill. This is a very serious condition, and it's not uncommon for the client outcome to be fatal.